So will there be any pediatric neurologists on board, or?
There would be.
Super.
There would be mainly pediatricians,
Yeah.
a few pediatric neurologists, and a few pediatric rheumatologists.
Super.
And yeah.
Yeah.
And,
great. And
this is actually, it's a collaborative. We are doing a project for the last 5 years on primary immune deficiency disorders.
Okay.
In collaboration with a research lab in Delhi, and that's known as the CSIR Institute of Genomics and Integrative Biology.
Super.
And we have our student, Dr. Vinod Skaria. I think he's not joined.
Vinod joined, yet to join.
Yeah, he's the person who has done work with zebrafish models. You could meet him at the end.
Okay. Yeah. Yeah.
Yeah. Shall we start then, Dr. Ashraf?
2 more minutes, Geeta, because we scheduled it at 8 p.m. Okay. So if we started early, somebody will miss the session. We will start the scientific session by 8:02 or 8:03.
Okay.
It is only 7:55 now.
So is somebody in your institute or one of the institutes running the interferon tests now, the interferon signature, or?
We are not doing it at Calicut.
Yeah.
Yeah. So what we do is, if we have patients who we think have type 1 interferonopathies, we would do the exome sequencing, but we don't do interferon signatures right here.
Yeah. Yeah. And have you seen much sting savvy or écart de Goutier or?
Yeah, we have. We have actually 2 siblings with suspected SAVI, and a few icardic, not many of icardic UTI.
Okay. Yeah.
But we're really interested on the work that you have been doing. I can find you. Okay, thanks. Yeah. Oh, okay, I see you. Shall we start?
Okay, Geeta, we will start now. Chief guest of the day, speaker of the day, Dr. Yanick, respected teachers, colleagues, and friends. Today is the 4th seminar series in pediatric hematology, organized by Indian Academy of Pediatrics, Kozhikode, Department of Pediatrics, Government Medical College, Kozhikode, CSIR Institute of Genomics and Integrative Biology, and Foundation for the Primary Immunodeficiency Disease. I request Dr. Ajit Kumar VT, Head of the Department of Pediatrics, Institute of Maternal and Child Health, Government Medical College, Calicut, to welcome the gathering. Over to you, Dr. Ajit.
Thank you, Dr. Ashraf, and respected teachers, Dr. Yanick, and dear friends and colleagues. It's an honor to welcome Dr. Yanick on behalf of IAP Calicut, Indian Academy of Pediatrics Calicut branch, Department of Pediatrics, Government Medical College, Kozhikode, and CSR IJB, and Guardian Consortium, and the Foundation for Primary Immunodeficiency. So on the behalf of all of us, I welcome Dr. Yanick, who is from the University of Edinburgh, and who is going to talk about a new entity called interferonopathies, which is a new entity and needs a lot of reading. I had read about it. I thought that we are going in more and more into molecular singularity, just like in astrophysics or quantum.
Thank you. Zoom
seminar. I also welcome all the teachers And I also welcome the senior pediatricians, office bearers of IAP Calicut branch and IAP Kerala, and all the faculties from our department, and all the delegates from far and wide who has attended, and all the organizers of this meeting who has come to attend the series. This is, I hope that this is the fourth in series of our series on immunodeficiencies, primary immunodeficiencies. And we are, Dr. Yanick, we are really indebted to you for accepting an invitation. And thank you very much. And I hope this talk will enlighten us for further research in this subject. Thank you.
Thank you, Dr. Ajit. Now I invite Dr. Mohandas Nair, Professor of Pediatrics and Pediatric Geneticists at the Institute of Maternal Child Health, Government Medical College Calicut, to introduce the speaker. Over to you, Dr. Mohandas.
Hello.
Hello, you are audible.
Okay. So, good evening, all. I am very happy and proud to introduce Dr. Yanick, who is a professor in Institute of Genetics and Molecular Medicine in University of Edinburgh. He is a clinician scientist with interest in monogenic disorders associated with upregulation of type 1 interferons. That's a set of inborn errors of immunity resulting from abnormal sensing, inappropriate stimulation, or defective negative regulation of type 1 interferon system. So it's a relatively new entity, and we are going to hear more about it. He has discovered the genetic basis of a rare disorder of brain called leukoencephalopathy with the calcification and cyst. And he has done work on Aicardi-Gottlieb syndrome. And with these words, I request Professor Yanick to give his deliberation.
Thank you, Mohandas. Now over to you, Dr. Yanick. Please unmute yourself. Okay.
Thank you.
To talk on human type 1 interferonopathies.
Lovely.
Okay.
Make sure the screen works again.
Yeah.
Okay with that?
Oh, it's okay. It's clear.
Lovely. Okay. Well, first of all, thank you very much to you all for the invitation to speak and for staying up or not going out on a Friday evening and staying in to listen to me. So, okay, I'm going to talk to you about this idea, this concept, this hypothesis around a set of disorders that we're referring to as the human type 1 interferonopathies. And I'm a clinician scientist, but I'm a clinical geneticist by training, so I'm interested in rare disease. And using rare disease as a means of deconvoluting complex biology, much as people use mouse models of whatever. So we can learn from patients and families affected by these rare monogenic disorders. Actually, at heart of this talk is an absolutely fundamental concept, and it's the concept of self versus non-self. And I think we're seeing at the moment the consequences of what happens when you can't fight infection. We as human beings are at war all the time with infections, viruses, bacteria, fungi, etc. And it's absolutely essential that we can repel and get rid of these organisms. And it turns out that the way we've decided to do that over evolutionary time is to recognize, if I limit myself for the moment to viruses, we recognize viral nucleic acid. So we have to be able to fight infection. If you cannot fight infection, you literally die. We need very efficient antiviral mechanisms. And what happens is when the virus enters the cell, our bodies are trained to recognize viral RNA and DNA. And once they do that, that recognition system induces a type 1 interferon mediated antiviral response. And you get consequently an antiviral activity. And essentially what this talk is today about is diseases, genetic diseases, where that goes wrong, where instead of recognizing it, this isn't about recognizing virus. In fact, these people are very good at fighting virus because they produce a lot of interferon. But the problem associated with this evolutionary mechanism for recognizing virus is that our own cells are replete, they're stuffed full of our own DNA and RNA. And so it begs an enormous biological conundrum. How do you differentiate your own nucleic acids from those of viruses? And to cut the story short, I would say to you that that is a very, you have probably several layers which try to ensure that you don't misconstrue self as non-self. But there are situations where mutations in specific genes mean that you do misrepresent self-nucleic acid as viral. And as a consequence, you produce an antiviral response all of the time. And essentially, interferon is a poison. It's like a disinfectant. It's very good for killing germs, but it's also very poisonous. And you really don't want to produce it. You want to be able to produce it in the right place at the right time for a shorter period of time as you need it, not all the time, which is effectively what's happening in these individuals. So in 2011, we wrote this little opinion piece, if you like, suggesting that there would be a novel set of inborn errors of immunity associated with too much interferon. And that's what I'm going to talk to you today about. So I think that, you know, one of the problems, in inverted commas, I have is that when I talk, you know, people say to me, well, Yanick, you're just a stamp collector. You're just interested in rare things because that's your job, and you know, but it's not very interesting. It's not heart disease. It's not stroke. It's not inflammatory bowel disease. And of course, these things are rare. But as I said, I think what they can do is help us deconvolute complexity and help us understand some of these other more common scenarios. So antiviral signaling, autoimmunity, and autoinflammation. And actually, what I think is also possible. I mean, the immune system is rarely it's not a binary phenomenon. And if you actually think about it, I mean, the coronavirus, the pandemic is showing us just one example, just the latest example of how important it is to be able to fight infection. And I would not be at all surprised if there are polymorphisms in genes which mean that some people are better at fighting infection because they either produce a small amount of interferon all the time, which acts as a kind of low-grade disinfectant, or they are very, very good at producing interferon as soon as they are infected by a virus. And I think possibly the kind of flip side of that will be that those individuals are the very people who are predisposed to developing things like systemic lupus erythematosus as just one possibility. So here's a definition. These are monogenic disorders in which there's an upregulation of type 1 interferon, which may be directly relevant to disease pathogenesis. And I'm emphasizing the second part of the definition here, because clearly the upregulation of type 1 interferon is present in all of the diseases I'm going to be talking about. But I'm actually not that interested in biomarkers. I mean, of course, one's interested in biomarkers, but you know, if that's the limit of it, in terms of this hypothesis, this classification, then it's not so interesting. What I'm more interested in is the idea that not only is the type 1 interferon system induced, but the interferon is actually causing damage. And the reason why that's very important is because if that's true, then essentially any anti-interferon therapy might be relevant in these disorders. And I've already suggested during this talk that this is an hypothesis, and it is at the moment. I mean, it may all be proved to be, at least the second part of the definition may prove to be false, because until we have medicines which can directly downregulate interferon signaling, and we use them in individuals and determine whether those medicines have an effect or not, I think we're going to be, the situation is going to be unclear as to whether the interferon is actually having has a pathological role in these disease processes. Yeah. Okay. So I would say to you that the type 1 interferonopathies form a part of the spectrum of autoinflammatory diseases. So these are clinical disorders marked by abnormally increased inflammation, predominantly mediated by cells and molecules of the innate immune system. And there is no part of the immune system that is more innate, if you will, than the antiviral interferon-mediated response. So we are talking very fundamentally about an auto-inflammatory process. But I think also what we see in some of these cases is what I describe as a spillover into autoimmunity, because, you know, actually the adaptive immune system, of course, the adaptive and the innate immune system talk, and the innate immune system induces changes that in the adaptive immune system. So there is a conversation going on with feedback and forward and negative. So, but I think at heart, at base, these are auto-inflammatory diseases. So you might ask yourselves, or I think it's a good question to ask oneself, is how come, if this is so, you know, if this is all true, how come essentially I was the first person to suggest this concept in public in 2011? Why weren't people doing this kind of thing before? And why weren't people making these kinds of diagnoses before, or at least recognizing what they were diagnosing? And the reason is because it is the case that there is no test, essentially still worldwide, there is no routine test in clinical medicine for determining if someone has got too much interferon signaling going on. Yeah, we just don't have that test as a routine assay. And what I can tell you is often, not infrequently, and quite often, in fact, in these individuals, the ESR might be normal, the CRP might be normal, the full blood count might be normal, liver function might be normal, etc., etc. And it's not until you look specifically for an upregulation of type 1 interferon signaling that you find it. So if you don't do the test, you don't know what you don't know what you're looking at. Of course, you know, to an extent now with exome sequencing, you can kind of get around that. But I would highlight just here at the moment as an aside, it's interesting when you look at the mutations in PSMB8, this proteasomal associated autoinflammatory syndrome, sometimes called CANDLE. I can't remember what the acronym stands for, but you know, these proteasomal associated disorders with too much interferon signaling. So that gene was identified in a specific phenotype originally and published in the American Journal of Human Genetics, but it wasn't until some time after that, when another group actually looked at the transcriptome, that they recognized the link to type 1 interferon. So, you know, really it is the case, if you don't look, you don't find. And what we have done is develop or take, well, the first on this slide at the top left is, as you look at it, is a test that we adapted from the lupus doctors, where we look at interferon stimulated genes. So interferon is extremely powerful, and a little bit of interferon goes a long way to produce a significant sort of set of consequences in the immune system. And what we do there is measure the expression of genes that are induced by interferon, so interferon stimulated genes, or ISGs. And we developed a test that the lupus doctors had first derived a long time ago, and have been using that test promiscuously and agnostically in any child, essentially, with anything that we thought might be related to this. And I also then make a second point, that it's not, or it wasn't at least, immediately obvious what the phenotype might be of too much interferon. You know, what would too much interferon do to your body? And actually the answer was, we're not sure. So we've spread the net very wide, and I think as a result of that, we found some interesting things, ourselves and other people. Now, you might then ask yourself, well, why measure the interferon-stimulated genes? Why not measure the ligand itself, the interferon? And I come back to a point I just made, that interferon is extremely powerful. And essentially, you can't measure type 1 interferons in the blood or essentially in any human tissue reliably using standard ELISAs, because the levels are too small, or that was what we suggested. And in fact, then we went on to prove that by developing what we call a digital ELISA. And I won't go into that further, but essentially that's what the bottom half of this slide is about. So this is where we actually measure the protein, or interferon alpha protein, at femtogram per mil level, so very low concentrations. And what we can find is there's a very nice correlation between the level of protein and the interferon-stimulated genes and some of the phenotypes we look at. So armed with these two assays, one then can go into the field and start looking at the diseases that are associated with too much interferon. So here's just a graph just to give you a flavor of what we're doing with the interferon signature. So these are on the y-axis as an assessment of the expression level of 6 genes, and the 6 genes are across the bottom on the x-axis. So these are 6 interferon stimulated genes, or interferon signature genes we've called them here, or ISGs. So these are induced by interferon. Now, at the beginning, you see these blocks of red bars, and just before the block of the red bar, for each gene, you can see you can just see a tiny bar that's in blue. And that blue bar is the composite data for 29 controls. So essentially, in controls, you don't see interferon signaling unless that individual has an infection, say. However, if you take, so this is what these refer to are the blood samples from an individual, a young woman with a gain-of-function mutation in STING1, causing a disease called SAVI, which I'll come on to in a bit. And what you see is that for every time we test her blood, so the first bar is at a particular time point for each gene, and then we've taken, here we've got 23 times we've taken blood from this woman. I don't think they're all depicted on here. Maybe they are. But my point is, it doesn't matter whenever I take a blood sample from this child. I could take it every day, I could take it every hour, I could take it once a year. It doesn't matter. When I take it, every time she has a tremendous upregulation of type 1 interferon signaling, a tremendous overexpression of these interferon-stimulated genes, as if she's infected by a virus all the time. But there isn't a virus. What's happening here is she's misrepresenting her own, well, here there's a constitutive activation of STING, and it's as if she's misrepresenting, she's being chronically stimulated by a virus, but there is no virus. And then with our protein assay, this is a way of measuring the interferon alpha protein. And what I want you to, if you just look at panel B for a moment, what you have in the CNS infection column is what the levels of interferon that we measure when people in a set of children with a viral meningitis, essentially. And these are the kinds of levels, 10,000 femtograms per mil, that you find where a child is infected with a viral encephalitis or meningitis. So, and then if you go onto the other side, onto the left-hand panel, in the far right with the colored balls or the colored dots, those are the kind of levels we see in the blood of some of these patients with Aicardi-Gouttier syndrome and STING. And you can see that for some of those individuals, the levels in the blood are as high as the levels that we see when someone has an acute viral infection of the central nervous system. What I'll also just draw your attention quickly to is that we find that patients with juvenile systemic lupus erythematosus, or well, not just juvenile, but also with juvenile dermatomyositis, they also have high levels of interferon. Both those diseases are well recognized to have an association with type 1 interferon signaling. So to cut the story short, then, we've been looking for genes that are associated with too much interferon. And essentially what we do is we find, we refer to a patient with a phenotype. And I don't really care what the phenotype is. We'll do the interferon response. If it's abnormal, we'll say, well, okay, it could be a red herring, could be an infection. I'm not quite sure. Let's do it again. So we do it again. And if we do it 3 or 4 times and it's always raised, then we know we're onto something. And of course, if we recognize the phenotype, we'll go straight to genetic testing. But if we don't, we do this process. And when we do that process, if we find this upregulation of interferon signaling persistently, we'll then go on to genome or exome sequencing. And in that way, you slowly accrue genotypes associated with too much interferon. So that was the situation we were at in 2016. Essentially, mutations in any of those boxes in blue were associated with too much interferon signaling. In 2020, this is where we are now. So there are over 30 monogenic disorders that I could argue can be classified as type 1 interferonopathies. And so this repertoire, this stable of disorders is increasing, and we're learning various things from doing that. And so I think the next slide is where I've rearranged some of these genes just to give you a little bit of a flavor of something. So above the line in this slide are some genotypes, and I've separated those from genotypes below the line. And essentially, all the genotypes above the line are molecules that are involved in what I'm going to call the metabolism or the sensing of nucleic acid. So these have been, the function of these proteins has often been explored by other people, innate immunologists, adaptive immunologists, virologists. But what I find very interesting, and what I think is in favor of our hypothesis that this is about a misrepresentation of self nucleic acid for non-self, is that all of these genotypes above the line are related to proteins that are involved in breaking down or disposing of self-nucleic acid or the sensing of nucleic acid. And I think this is a powerful piece of evidence in favor of that hypothesis that you are misrepresenting self-nucleic acid as non-self. Okay, so actually the clinical story begins in Paris, where I have one of my labs at the Necker Hospital. And 2 very famous pediatric neurologists, the Pele and Maradona of pediatric neurology, Yanick and Françoise Gouttier, and they were intrigued because they identified a number of children who, of course, in 1984, the neuroimaging, MRI didn't exist, and people were still doing encephalograms, but they had CT, and they were surprised because they saw a number of patients who they thought had been infected by a virus in the womb, but they couldn't find a virus. And then they noticed that in some of these families, the parents were related to one another, they were consanguineous. And in some of these families also, they saw recurrences in siblings. So these were all kind of warning signs that this wasn't a virus, it wasn't an infection, but actually it was a disorder that looked like infection, but was genetic in basis. And I'll just see if okay, so then what they did was they, a bit further along the line in 1988, they were using an assay of interferon activity to assess herpes simplex encephalitis. And so they decided that because they had a disease that clinically looked like infection, they wondered if this antiviral activity, this interferon activity, was present in these patients. And lo and behold, it was. So this is a really, beautiful piece of clinical imagination, and using your imagination to make a really quite a profound biological step forward. So I've talked about, I've already shown you a version of this slide. These genes in the red bars are the 7 genes that have been published up until last week, when we published 2 more genes for Aicardi-Goutieres syndrome in Nature Genetics. But these are the ones that we've been using, people have been working on for quite a while. And the TREX1 is the AGS1 gene. TREX1, what does it do? Well, it's involved in chopping up bits of DNA. RNase H2, A, B, and C are part of a complex that's involved in removing RNA molecules from RNA-DNA hybrids or DNA-DNA sandwiches. SAMHD1 is involved in controlling DNTP pools, and these are the building blocks of nucleic acid. ADAR1 is a double-stranded RNA editing enzyme, and MDA5 is a sensor of double-stranded RNA in the cytosol. So really, AGS fits so perfectly around this paradigm of self, non-self, and problems with discriminating self from non-self. So one of the things I want to emphasize here is, and I don't know how many, if any, but if there are any pediatric neurologists in the audience, I just mentioned this, but it's a more general point, which is not something that you don't know already, but clearly what's happened with the advent of exome sequencing is that, once you find a gene, when we're looking for a gene, we tend to be quite specific about the phenotype and quite particular about the patients that we sequence. But once you have a gene, you can be then quite liberal about trying to think about the extent of the phenotype. So we've learned in many different walks of medical life that the phenotypes for a disorder are much broader than we first realized. And this is just one example. So it turns out that mutations in any of ADAR1, MDA5 or FEH1 and RNase H2B can present as a spastic paraplegia. So if you say to a lot of doctors, what's Aicardi-Goutieres syndrome? They say, well, it's a terrible disease. It's a profound neurological problem of children. Usually occurs in the first 6 months of life. Children are left severely disabled without any useful hand function, motor function, and communication. And that's kind of true, but actually mutations in the same gene, in this case, for example, can cause a pure spastic paraplegia. So stiffness of the lower limbs with completely normal neuroimaging and completely intact intellect and completely normal upper limb function. And really, essentially, as a non-progressive disorder. So one should not be dogmatic about all of this. And I put this up partly because it's interesting. I've mentioned that interferon is a poison, and here we're suggesting it's a neurological poison. And there's actually a lot of data on the potential risks of exposing your brain to type 1 interferons. And this is just one example. When people were using interferon as a therapy for hemangiomas and vascular anomalies in young children, interferon is actually quite good at shrinking this kind of stuff. But actually there was a flurry of papers describing the onset of spastic diplegia in patients who are being treated with interferon. And then when the treatment was stopped, the problem would resolve. So I think that, that's actually another bit of data in favor of this hypothesis. So another phenotype that we've seen, this is a neurological phenotype, but is bilateral striatal necrosis. So these are children who are completely fit and well, and then often seem to develop a problem after a very relatively mild but notable infection, and suffer profound damage to their basal ganglia and left with a very severe, horrible dystonic lock-in syndrome, often with very good preservation of intellect, and it's something that looks rather like a lot of mitochondrial disorders actually, and it's not so uncommon in that phenotype. Now, some friends of mine, good colleagues that I worked with in Glasgow a long time ago now, in the 90s, were the first people to describe the association of skin disease in with Aicardi-Goutieres syndrome. So, and I would say to you in many respects that Aicardi-Goutieres syndrome is a disease of the brain and the skin. And so these were called these vasculitic chilblain-like lesions. And I'm not sure that's a very good term, but there we are, we're kind of left with it now. And these are some other examples of the kind of skin lesions that you see in patients with Aicardi-Goutieres syndrome and other type 1 interferonopathies, which I'll talk about in a minute. So we described a mutation in TREX1 associated with what's called familial chilblain lupus. So this is a dominant disorder where there's normal intellect, and but you get these kinds of chilblain-like lesions, and you can get destruction of the cartilage. They're most commonly on the peripheries, so they're much worse in the cold. Hands, feet, ears, nose. Those are the classic sites of affliction. So now what I want to do is I want to say to you that this is another piece of data in favor of this hypothesis that it's the interferon that's doing the damage. So here on the top left, we have the feet of a child who's now dead with biallelic mutations in RNase H2B, so fairly classic Aicardi-Goutieres syndrome. In the middle on the top and with the blue background are the hands of a young woman who's now dead, who has biallelic mutations in ACP5. She has a disease called SPENCT. On top right are the hands of a young man who's still alive with a STING1 gain of function mutation. He has SAVI, but without any lung disease, as it turns out. Then in the middle on the left is a picture I stole from the Goldbach-Mansky 2014 New England Journal of, sorry, that's not true. The middle on the left are the cheeks of the boy on the top right. So those were his cheeks when he was a little boy, and those are his hands at the top right. And then on the bottom left is a picture I did steal from the New England Journal paper from Rafaela and her colleagues in 2014. And on the bottom right are the cheeks and nose of a 70-something-year-old, I think, Japanese woman with a dominant negative heterozygous mutation in TREX1. Now, I'm not a dermatologist, but really, I don't think you have to be a dermatologist to see the overlap in clinical phenotype here. And no one would have any reason to put TREX1 in terms of the function of the gene before all this story sort of came out would be no one would have put TREX1 together with STING, together with RNase H2B, together with ACP5. And you know, it's not immediately obvious why you would put these things together. But the reason, I believe, why we should put these things together, the reason why there is such remarkable, what I consider to be remarkable clinical overlap, is because all of these diseases are associated with too much interferon. And it's the interferon which is the common aspect in this story. So this is just to say, I think the skin lesions in SAVI are essentially the skin lesions we see in Aicardi-Goutieres syndrome. I don't see any difference. And it turns out we've described dominant mutation in TREX1 causing autosomal dominant familial chilblain lupus. And this is the same thing. This is a dominant mutation here in a gain of function mutation in STING, causing familial chilblain lupus. So you're seeing the overlap of these disorders. Now, another clinical sign that I want to emphasize to you is the presence of intracranial calcification, best seen on a CT scan. And you know, it's the same message. We've got mutations in any of the AGS-related genes. We've got mutations in ACP5. We've got mutations in ISG15. We've got mutations in PSMB8. And in all of those cases, not always, but in any of those genotypes, we can find intracranial calcification. Intracranial calcification is a very good marker. I mean, there's many causes of ICC, but it is a very good marker of too much interferon signaling in your brain. And I just point out to you also that even though no one, to my knowledge at this point, has ever published a STING a SAVI patient with with neurological disease, when we screen patients with SAVI by doing a cerebral cranial CT, in some of these individuals, these are 3 different scans from 3 different individuals, we see the presence of basal ganglia calcification. And we've got a paper under review showing that actually STING patients with SAVI do have abnormal levels of interferon in their cerebrospinal fluid, but not as high as you see in Aicardi-Goutier syndrome. So again, it really, this feature emphasizes the overlap, and the overlap is, I believe, explained by the common fact that all of these genotypes are associated with too much interferon signaling. I just emphasize the breadth of joint disease and of skin disease that you can see in these cases. I think you really, one really should be quite open-minded to what interferon can be associated with this. So this is a sibling pair from Australia who have biallelic mutations in a gene called SAMHD1, AGS5, and the telltale sign, the only reason why the clinicians got to the diagnosis was because of these little ear lesions in the brother, yeah, and otherwise they were presenting with a non-destructive but deforming arthropathy. That was I think that was the female child. And then this non-specific rash. So, you have to be, it's worth thinking about these things. We see here you have some paniculitis and lipodystrophy. This is a boy, this time an American child with mutations in SAMHD1. And he's got neurological problems, but he suffers really badly from his skin disease. So one of the things that we described was the presence of intracerebral large vessel disease, or large medium vessel disease, and moya type phenotype in patients with SAMHD1. And so although mutations in any of TREX1, the RNase H2B complex, SAMHD1, ADA1 and MDA5, and now LSM11 and U7 can cause Aicardi-Goutier syndrome, there are some differences between these genotypes. So I mentioned the bilateral striatal necrosis is essentially specific to mutations in ADAR1. And this kind of phenotype that is on the slide now is essentially specific to mutations in SAMHD1, not completely so, but essentially so. And one of the things I want to emphasize again, or I'd like to bring up, I've already talked about phenotypic or variable expression within a genotype, but I also want to say that you can see variable expression within a family. And I think I will be touching on the fact that we also see complete clinical non-penetrance. So here's a story. This is an email from 2018. 2 girls, 16 and 18 years of age. Saw them first when they were 5, or one of them was 5, for problems with the musculoskeletal system, hip and shoulder pain, restricted joint movement. Then one of the children had a stroke at the age of 2, was diagnosed with moya. She had been normal with development up until that time, as had a sister until late childhood. Then the sister developed moya, or had moya at the same time. And both of them had this perniosis, or this chilblain-like lesions. So within this family, there's some variability in the expression of the disease. And I've seen, I saw a family in the States once where one of the second born child had fairly classical Aicardi-Goutier syndrome with intracranial calcifications and white matter disease in the brain, but no cerebrovascular anomaly, no moya. Her older sister had been completely fit and well, but was noted in the wintertime to get chilblains. But otherwise, she was at university in Boston. But because the diagnosis had been made, and because we knew about this association, that older sister, with all she had was these chilblains, when they did a brain scan, they found she had very florid moya type features. So remarkable variability within that family. So I'm going to sort of not change tack, but I want to sort of take you to another phenotype, but it's all part of the same thing, in my opinion. And it's a phenotype that's been referred to as Singleton-Merten syndrome, and it's due to mutations in MDA5 or IFEH1. And these are the very same mutations that can cause classical Aicardi-Goutieres syndrome. So I don't think, I mean, well, I think the phenotype is quite different, but pathologically, it's clearly the same disease. And in fact, we see patients who have a kind of overlap of both AGS and Singleton-Merten syndrome. But essentially, this is an interesting disease where you get calcification in the brain, you get calcification of the aortic valves, which is what usually causes death. You can get calcification in the brain without any neurological problems manifesting. You get these unusual joint problems, you get psoriatic type features in the skin, and you get a retention of the primary dentition and a subsequent loss of the secondary dentition. And as I said, it's sometimes referred to as Singleton-Merten syndrome. So this is a remarkable family. So the hands on the left and the feet below them are those of a young woman in her 20s. And the hands on the right, as you look at the screen, and the feet below them are the hands and the feet of the 23-year-old's mother. So this is a dominant disease, again, due to mutations in MDA5, or otherwise known as IFEH1. And remarkable deforming arthropathy. But what's interesting about the imaging in the joint imaging in these individuals is that so you can get subluxation of joints, you can get rupture of tendons, you can get insertion, calcification at the insertion of the tendons. You can see a complete loss or a loss of teeth, and you can see this calcification of the aortic valve, and you can see some calcification in the basal ganglia. So there's the calcification of the aortic valve, lack of teeth, calcification at the insertion of the tendons there and there, and then this subluxation. But the joints themselves are pristine. So it's a deforming but non-destructive arthropathy. And a little while back, we also published mutations in a molecule called DNase 2, which I'm not going to go into here, but one of the patients had these hands. And at that point, it sort of the penny began to drop a little bit. And I realized that actually we were seeing these kinds of hands in all sorts of places, and they're actually reminiscent of this rather enigmatic clinical feature referred to as Jacquet's arthropathy, which is previously described in the context of psoriatic arthritis and essentially, well, most frequently psoriasis and SLE. Both of those disorders are associated with too much interferon. And actually, you know, really, these are all kind of Mendelian mimics of that non-Mendelian phenotype. And again, as I've said for the skin, as I've said for the cerebral calcification, I believe the commonality is because there's something going on with interferon. And essentially what I think is happening here is that this is some kind of fasciitis, some kind of, you know, it's about the facial planes, and some way you get this destruction or this deformity without joint destruction. Okay, I'm not really going to talk about this very much. I've already talked about, I've mentioned Sting in very many occasions. The pediatric rheumatologists love SAVI. And I found it quite interesting because actually, you know, I think it's worth pointing out that this whole field really developed from the neurologists, but it didn't really take off clinically, I would say, in some respects, until the rheumatologists were involved. And I think one of the interesting things about rheumatologists compared to neurologists, and this is no disrespect to either, is that rheumatologists have been involved much more in with the use of biologics. And as a consequence of that, what I think was interesting was that the patients with SAVI, described by Raffaella and her colleagues, they'd already been exposed to a lot of immunosuppressant type therapies and biological type therapies, and nothing had worked. These children were dying of their lung disease. So SAVI is essentially a disorder of the skin and the lung, yeah, and sometimes the joints. These children were dying of their lung disease. And it wasn't until Raffaella and colleagues in Paris actually described this with 2 papers in 2014, and then started using JAK inhibitors. So these are, I'll come back to that in a second, that actually they were finally getting some kind of clinical effect. And I think that's very interesting because, you know, that just goes to show that, that this is quite specific type of inflammation. So those are some of the skin and joint problems you can see with, you know, terribly florid cases of SAVI. And these are all, this is an image that's taken from the fantastic supplementary information file associated with Raffaella Gobert-Medsky's 2014 wonderful New England Journal paper. And I've shown you some pictures already of other patients that we've been looking after. It's a type 1 interferonopathy. I've already shown you this slide. Yeah, you can see. So just to point out, you can see here, this is a child, and we've taken her blood on all of these occasions. The first number is her age in decimalized years. And this is what we call the interferon score. 63 is enormously high. But what I want to point out to you is that the first time we ever took a blood sample, she was 3.76 decimalized years. And then in this graph, the last time we took a blood sample from her, she was 8 years of age. So as I mentioned very early on, it didn't matter what age she was. Every time we took a blood sample, it was absolutely grossly abnormal. So these are some other patients that we described a few years ago now with mutations in another part of the gene. That doesn't really matter for today's topic, but you can see this, sometimes you see this livedo type problem on the skin, but the thing they really die of is the lung disease. So the fact there's lung disease actually brings me to a new kid on the block, which is this disease called COPA syndrome. And I reviewed the paper for COPA syndrome. So COPA syndrome essentially is a disease of the lung, of the kidney, and the joints. And they also produce autoantibodies. And it was described in this very nice paper from 2015 in Nature Genetics, and it was described as an autoimmune disease. And I reviewed this paper before it was submitted to Nature Genetics, when it was actually being reviewed at the New England Journal of Medicine. And what I said at the time was, where I struggle with this manuscript relates to the claim that the disorder is autoimmune. So I asked, is this really autoimmunity? This was what I wrote back to the editor. I said, could it not possibly be a form of autoinflammatory disease with occasional spillover into autoimmunity, e.g. like the Mendelian inflammatory disorder Aicardi-Gouttier syndrome? I would ask the authors to consider an expression array looking for further clues to the pathways deranged in the patients they report. Could this be related to an induction of type 1 interferon signaling? So that was in June 2014. The paper was published in June 2015. And ever since I'd seen that paper, and as soon as it was published, we started actively looking for patients with COPA to prove or disprove my hypothesis. So here's a story. This is the first patient that we identified with COPA syndrome. Can I ask someone, you're all still there, and how am I doing for time?
Yeah, we are perfectly fine with the time. Please, okay. Continue.
Thank you. So here's an 11-year-old girl presenting at the age of 2.5 years with joint pain and swelling and with positive anti-nuclear antibodies. So she was treated with steroids and she had a clinical remission. Then she developed, lung disease then became apparent with cough, clubbing, decreased exercise tolerance. And at 6 years of age, chest CT demonstrated interstitial lung disease, okay? And she and her mother were found to have this bona fide, classic, no doubt about it, heterozygous mutation in this gene called COPA. And one of the things I want to point out to you at this point is about clinical non-penetrance. So her mother, carrying exactly the same mutation, was completely clinically normal. Not a scratch on her, nothing. Full, we're not talking about mosaicism. She has the mutation in all its glory, and she has nothing, whereas her child is dying of this lung disease and has this problematic joint disease. So this was where we started to prove the hypothesis. So essentially, on the left-hand side, we have our classic interferon signature with 6 genes. And on the right-hand side, we have our more modern interferon signature with 24 interferon-stimulated genes. You could measure more if you want. And what I want to show basically is that it doesn't matter whenever, just like the patients with STING, whenever I take a blood sample from this child, she has very significant upregulation of type 1 interferon signaling. So they missed a trick. In that 2015 Nature Genetics paper, they missed a trick. They ignored my advice and they missed the link with interferon. And I'll come back to that in a moment. So here's another story. Disease initially manifesting at age 2 years, life-threatening recurrent alveolar hemorrhage. So in the earlier slide, we found we had interstitial lung disease. Now we've got alveolar hemorrhage. So this girl can drop her hemoglobin. I mean, she becomes famously anemic and kind of drowns in blood for a while. And she's got infiltrating lesions on her chest CT, intra-alveolar bleeding, and interestingly enough, no features of vasculitis. And she's had a lot of these problems. And she, again, was found to have a bona fide heterozygous dominant mutation in COPA. And again, the mutation was inherited from her completely asymptomatic mother. Really quite remarkable. And what you see here is, again, she has an interferon signature. And one point I'll come back to, I think, in a moment, but her levels are in green. So this is on 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 6, 7 occasions that we've taken the blood, and all of these 6 ISGs are high compared to the little blue columns on the left, which are the controls. And interestingly enough, her mother has a touch of an interferon signature, if I can put it that way, but really very minimally raised. So the phenotype is reflected in the interferon signature here. So here's a third scenario. Proban, 15-month-old girl, born early, discharged at 3 months with presumed chronic lung disease of prematurity. Then readmitted soon after with failure to thrive. And she's got widespread ground glass interstitial changes on a X-ray or CT scan of her lung, and she had a lung biopsy. Her mother had been diagnosed with rheumatoid factor positive polyarticular JRA in early childhood, juvenile rheumatoid arthritis, with no evidence of destructive arthropathy. She had a lung biopsy at 8 years because she had abnormal liver function, pulmonary function. And she was diagnosed with interstitial lung disease. And the maternal grandmother had a similar story. She'd been diagnosed with rheumatoid factor polyarticular JRA, age 16 years, and she had a lung function problem. And she actually underwent a lung transplant, and then she died at the age of 38 years. So does anyone want to hesitate, or anyone dare tell me what the diagnosis is? Go on, someone. Okay, well, I mean, we've just talked about a COPA patient, so the answer should be COPA, but it's not. The answer is STING. And what I'm trying to emphasize to you here is the remarkable overlap, in some cases at least, between SAVI, or mutations in STING1, and mutations in COPA. Okay, so you can start to sort of think about these disorders. I'm not going to go into this, but essentially, STING, if you think STING, think COPA. If you think COPA, think STING. Now, there are some differences, and the most obvious difference is that in STING, we've never seen a COPA patient without skin disease. Sorry, we've never seen a COPA patient with skin disease. Okay, but otherwise, I think there's a lot of clinical overlap. It's true that alveolar hemorrhage is, at least at this time, considered to be the more classical phenotype associated with COPA mutations, but that's not completely true. We see ILD in COPA disease, in COPA syndrome, and we can see that at least, well, we know of 2 cases with alveolar hemorrhage with sting mutations. So I would encourage you, particularly those individuals who are interested in lung disease, to think about these two disorders. And I just put it as an aside. It turns out there's a nice paper recently, I think coming from India, in fact, I might be wrong about that, but describing patients with COPA mutations and hands that remind me very much of that Jacquard arthropathy that I've already talked about. So I won't go into that, but the mutations in COPA all cluster in one part of the molecule. And essentially what those mutations do is they interfere with the ability of COPA to transfer other molecules called cargo molecules. And what we and others have shown recently and published in JXMed earlier this year is that sting normally sits on the endoplasmic reticulum, but actually it seems that there's a bit of kind of leakage, if you will, and that sting can kind of transfer from the endoplasmic reticulum to the Golgi, and that you have a kind of feedback or a homeostatic mechanism where COPA carries sting back to the ER. So you get this kind of leakage, but then it comes back the way because of the function of COPA. And when you have mutations in COPA, that doesn't work. And you've got, at that point, you've got constitutive signaling of sting as if it's been switched on in a SAVI by a SAVI mutation, or as if there's a chronic infection. So that, I think, explains very nicely, in fact, the overlap between these 2 disorders. And there was this nice flurry of papers, including one from our group. I won't show you that, but essentially because of this, this is a large panel of interferon stimulated genes. You can see COPA is really magnificent in terms of the number of ISGs that are overexpressed. And because of that, people are starting to use these drugs that block type 1 interferon signaling. I won't talk about that. Either. So I've mentioned CANDLE. I can never remember what the acronym stands for, but it's this proteasomal disorder. Looks quite like a progeria in some respects to me there. There's some other pictures. This is the paper where so this was the paper that first described mutations in the gene in 2010. But this paper came out sometimes after that. I can't remember the year now, where they actually described the interferon signature. So it's another one of those stories where, if you don't look, you don't find. So they hadn't done the transcriptomics, so they didn't find the interferon aspect. This is another proteasomal disorder. And I don't know why I put that there, just to mention that there's this overlap between, well, I've mentioned already that people with lupus and dermatomyositis have an interferon signature, or can do. So these are papers from 2003, and that's where we copied our interferon signature from. And it turns out that mutations in TREX1 can be associated with common or garden lupus. I've mentioned about familial chilblain lupus, even though I don't think that's a very clever name for that disorder. I mentioned about moya disease and large vessel disease in the context of SAMHD1. I said it was almost exclusively associated with SAMHD1 mutations, and that's true, but you can see it in these rare monogenic causes of childhood lupus. There's another example. I showed you a picture of this young woman's hands before. So we became interested in monogenic causes of lupus and identified mutations in a disease called SPENCT, So the clue here is they get this platyspondyly and problems with a spondylo chondrodysplasia. And so they're quite short. These people are short, actually. But what's interesting to me is that they really have a rip-roaring, proper lupus diagnosis. So this is a really amazing mimic of congenital lupus. We, a long time ago now, almost 10 years ago, we found mutations in tartrate-resistant acid phosphatase or deficiency of TRAP due to mutations in ACP5. So we were interested in monogenic lupus, and we still are to an extent. So I'm just going to finish off with a note about treatment. So, you know, I go back to my hypothesis. I'm interested in interferon signaling as a marker of disease, but what I'm most interested in is the idea that interferon is actually driving the disease. And if interferon is driving the disease, then if there are medicines one could use to block interferon signaling, either reduce the amount of interferon or block interferon signaling, then maybe you would do some good. So it turns out that interferon is produced by cells and secreted, and it then attaches to other cells and triggers and signals to them by attaching to the interferon receptor, the IFNAR receptor, or IFNAR. And a constituent of that IFNAR receptor is a molecule called JAK1. And it turns out that there are JAK1 inhibitors on the market. And so we and others have been using these JAK1 inhibitors in some of these disorders that I've been talking about today. And I think we were the first people to describe the use of JAK1/2 inhibitor ruxolitinib in SAVI or CANDLE in 2016. And we saw a positive effect. Difficult in the lungs, you know, especially if you've got a lot of damage already. I think it's very difficult to imagine you can go backwards. But in the skin, we saw quite dramatic changes. And then we've also been involved in using them in the context of neurological disease. This is an amazing story. This is a young woman who has a dominant negative heterozygous mutation in TREX1. She has completely normal intellect, no neurological problems, but she has this devastating skin disease, as you can see. And, you know, real problems with getting footwear and going to school and, you know, all that kind of thing. And she'd been on all sorts of medicines, you know, immunosuppressants and the biologics, etc. So this is her on day 0 before she starts ruxolitinib. And this is her 3 months later, or 2.5 months later after starting ruxolitinib. So this molecule, this treatment was having a very significant effect. Now we used it because we were using it. The hypothesis was that interferon is driving the disease, that interferon signals through JAK1, and that these drugs block JAK1. They don't just block JAK1. So I can't say to you for certain that this is how they're working, but I think this is another bit of data in favor of the hypothesis that the interferon is actually driving the disease. That's her as a bit older. Well, that's her hands and feet again, as I've just shown you, but that's her a little bit older now with really very good skin control. I won't go into that. There's papers on the use of JAK inhibitors from other groups as well, Rafaela's group. People are using it in the context of ruxolitinib, of dermatomyositis. I won't go into that. I'll just mention one thing. If this is about self, non-self, a failure of non-self self-discrimination, then there's only 2 places in the cell that you have DNA or RNA, and that's the nucleus and the mitochondria. And we're just about to publish a paper that shows that some mitochondrial disorders are also associated with interferon signaling, because the mitochondria are full of their own DNA and some RNA. And I think that's a theme that's going to be developing over the next few years. I've already shown that slide. Those are the genes. Those were the genes that are associated with Aicardi-Goutieres syndrome. There's lots of interest in using these JAK inhibitors in this context and other contexts. But I want to share with you a final story before I leave. So this is a story of a young man, or 2 young men, a boy who was diagnosed with classical Aicardi-Goutieres syndrome due to biallelic mutations in RNase H2B. He had a brother who we saw at the age of 4 months, at that time was completely neurologically normal. And so at 5 months of age, we started him on ruxolitinib, a JAK1/2 inhibitor, and he was completely asymptomatic at age 14 months, and his interferon signaling is improved over time. It didn't go back to normal, but it improved. And we began to think that, wow, maybe actually we had solved the problem, that if you caught acardiogugisinin young enough, you could actually do some good, because a lot of children with AGS are initially clinically normal and then something happens. However, unfortunately, at the age of 14 months or 15 months, he became symptomatic. So I got an email on the 13th of January 2019 saying, "Dear Yanick, I wanted to update you regarding, unfortunately, we admitted him yesterday with acute onset, last 3 weeks of deterioration of milestones." So essentially, this boy had developed acardiogugisinin syndrome, despite almost 10 months of therapy with a JAK inhibitor. I don't think this is the answer to everything. And there might be a very simple reason for that, actually, which is that we know that the concentration of the drug ruxolitinib in the blood versus the concentration in the cerebrospinal fluid is only about 10% in the cerebrospinal fluid. So you've got you've got much higher levels in the blood than in the brain. And we've just published this as a small letter in the New England Journal if you want to see a bit more detail about that. But what I think is important to remember is that there will be other drugs. So there's a lot of excitement about blocking STING, CGAS, and other molecules in the interferon signaling pathway. And I really do think that there are going to be drugs for the effective drugs. They're going to be very competent blockers of interferon signaling. And then we'll be able to use these drugs, discrete inhibitors of type 1 interferon signaling, and we're going to be able to determine if the hypothesis that the human type 1 interferonopathy hypothesis is true, because we're going to be able to use those drugs and see whether they make a difference. Okay, I'm just going to finish off and thank the people in my lab in Paris, the people in my lab in Edinburgh, and various colleagues who've been great collaborators and friends, many of them, and then more generally to all collaborating physicians and patients. And we receive fairly regularly samples from colleagues in India. I'm involved in a paper at the moment about C1q deficiency, and I'm very happy to try and help if that's interesting to people. So I'll stop there. Thank you.
Thank you very much, Professor Crow. That was fantastic talk. Shall we go to the questions or comments in the chat box?
Yeah.
Dr. Nihas, please.
Do you want me to read them and answer them?
No. Dr. Nihas?
Yeah, yes, ma'am. Yes, ma'am.
Yeah.
So we have some comments and some questions in the chat box here. So I'll go through one by one. The first comment is the issue of self vs non-self brings us to the root question: what is self or non-self? There are parts of DNA which are derived from genetic material of ancient viruses known as retropossessible elements integrated in our genome. And also there is more microbial DNA in humans than human from the normal microbial flora. So your comment on that, sir?
Yeah, so I think it's a great question. And I touched on, I really didn't want to go into this particularly in detail, but in the talk, which is why I didn't. But I did touch on this issue when I said that in the cell, there are essentially two sources of nucleic acid, the nucleus and the mitochondria. So people, I think people know that only 1% of the genome is coding for protein. So what's all the 99% doing? And people refer to it as junk or dark matter. It turns out that, like when you go to the beach and you look up at the cliffs, you see the kind of geological strata. if you look in the human genome, about 40% or something like that is actually turns out to be ancient virus, and that we've actually assimilated into our genome. I mean, it's really quite an extraordinary thing. And so that's what people refer to essentially, I think, when they talk about, well, yeah, when they talk about retroelements or retroviruses. And we were very interested in the possibility that retroelements, so these are viruses that are in our genome and they want to reproduce themselves. And we became very interested in that as a possible mechanism or source of self-nucleic acid. So we undertook a clinical trial using reverse transcriptase inhibitors. So these are the same drugs that are used in HIV. And we published that a couple of years ago in the New England Journal, and we've actually got another grant now to look at that in more detail. I don't know if that is the answer, but we were interested to explore that. I think another thing that's come up is that you can derive self-nucleic acid from DNA damage and DNA repair, and then I've mentioned the mitochondria. As far as microbial DNA, I have no idea. I mean, if I was to write if I could implicate microbial flora in acardioguti syndrome, I'd probably get a load of grants because it's extremely fashionable. Whether or not it's I don't know. I don't know how to interpret the flora data, but yeah, I can't say anything more about that. But the retroelement stuff, we're interested in and we are exploring. Yeah, thank you. Good question.
Thank you, sir. The next question is, the type 1 interferons are not in the dynamic range that can be readily measured by conventional ELISAs, necessitating measurement with more expensive digital ELISAs involving rolling circle amplification on commercially available platforms. So is there room for cheaper home-brewed assays based on rolling circle amplification, or are there any other biomarker which can be measured more readily? CRP is invariably low in patients with SLE who have an elevated type 1 interferon response. How does it fare in other type 1 interferonopathies?
Yeah, so I mean, I've already touched on the fact that we use these two assays. One's an indirect marker of interferon activity, and one is where we actually measure the ligand. Now, I think there's a kind of a sin by omission in my talk, which I'm happy to discuss. But essentially, we talk about type 1 interferons, but what do we actually mean by that? I mean, there are at least 13 subtypes of interferon alpha. Then there's interferon beta. And then we can also talk about interferon lambda, type 3. I mean, gamma I don't think really comes into this, but the interferon signature is a signature of interferon, type 1 interferon activity and 3 interferon activity. It's not specific. The problem with the ELISAs is that, as I mentioned earlier on, the interferon is produced at such low concentrations that it's difficult to pick it up with routine ELISAs. So we developed this digital ELISA assay. It doesn't work by rolling circle amplification. It sort of works by, essentially, it's a standard ELISA. But the reason how it works is because the plate has these tiny, tiny wells. And effectively, these wells are just big enough for one molecule of antibody and one molecule of protein to roll into the hole. And then you seal the well. So instead of so you then get a digital readout. But I mean, yeah, you're right, that is expensive. And it's only for interferon alpha or interferon beta. You can't have, we don't have it's for a specific protein. I actually think the best test is the interferon signature, because it captures an amplification process from the ligand to a signal that's generated by the ligand. And it's agnostic as to whether it's interferon alpha or beta or lambda. So, or gamma, in fact, for that matter. So I actually think that the ISGs is the best test. And as I mentioned in the talk, you can have plenty of these people can have normal ESRs, normal CRPs. So you can't go by, some of them do have markers of inflammation, but not all of them by any means.
Thank you, sir. The next question is, type 1 interferonopathies are good as a unifying concept supported by serotypic skin, CNS, or rheumatological lesions. But what is the explanation for different manifestation with the same variant, often in the same family?
Yeah, so I mean, I think it's fascinating. At the same time, I think it's important to remember that variable expression and even non-penetrance are well-recognized concepts throughout Mendelian genetics. For example, so tuberous sclerosis, neurofibromatosis, etc. One sees this phenomenon a lot of frequently. The simple answer is, but it's of no help whatsoever, is it's either environment or it's other genetics. So of course it could be other polymorphisms in genes, or it could be environmental factors. In the context of the type 1 interferonopathies, I mentioned the bilateral striatal necrosis, and I mentioned that this devastating destruction of the basal ganglia frequently happens apparently after a non-specific but notable infection. So when we first described that paper, I went and met several of the families, and it was when I was taking the stories from the patients, from the families, I was saying, tell me what happened. And I remember a family in Preston in Lancashire saying to me, well, our first child, he was fine, and then he got chickenpox, and then about 3 days later he had this devastating neurological onset of dystonia. And his brother he was fine as well up until 10 months of age, and then he got a diarrhea and vomiting illness, and then suddenly his neurology went off. So I think infection, is not unreasonable when we're talking about, these people are supercharged. It's as if they're supercharged to fight infection, and if you overwhelm the system with just, interferon is really toxic. So then the other problem at the moment is that people are saying to me, families now are also saying, we think it's vaccination. And, I don't know, because it could be. I'm not quite sure. Anyway, a good question. That's as best as I can do for an answer. Oh, I can't hear. Sorry.
Okay, sir. Can you hear? Yeah. Sir, next question is, have you come across pseudoangioma as a cutaneous feature as well?
Well, if I have, I wouldn't know it because I'm not quite sure what a pseudoangioma is, I'm afraid. But I don't recognize the term. I've never sort of really heard of anyone talking about it. So I think I would say no, but I'm happy to be proved wrong.
Okay. Thank you, sir. So next question is, patients with severe COVID-19 infection have been found to have anti-type 1 interferon and autoantibodies. Have these patients with type 1 interferonopathies done expectedly well with COVID-19?
Yeah, so that's an interesting question, and something that we have. So I know Jean-Laurent Casanova well. I mean, we're in the same institute in Paris, and he produced that remarkable paper in Science. It's a question we've talked about, but the problem is, and I think, well, of course one didn't know, but well, first of all these diseases are rare, so it's hard to get big numbers. The second is that all these patients have been hibernating. They've been extreme kind of lockdown because the parents are very anxious. So actually, the very few of them have been exposed. But I think it's one of the few saving graces of the COVID pandemic, and that children have been also have been protected, relatively not at risk. And so I think it's a super question, and unfortunately I can't really say. But what I can say is that I frequently hear the story. So some of these children are severely disabled, difficulty swallowing, they've got epilepsy, maybe all these kinds of risk factors for infection. But I frequently hear the story of parents saying to me, it's funny, despite the fact that he or she have got all these problems, they don't get all the infections that their brother or sister get who doesn't have Aicardi-Goudis syndrome. These people are not immunosuppressed. They are actually very efficient at fighting off infection. Yeah.
Okay, sir. Thank you. The next question is from Dr. Kishore. The
Yeah.
huge clinical heterogeneity in these patients, which often does not match with the interferon signatures, presents with the difficult question of who would respond to the JAK and optimizing parental expectations.
Yeah, so it's a good question. I'm going to dissect it just for a moment. I mean, I think the genotypes on the whole are very well reflected by the interferon signature. I think there are a couple of problems though. It's true that the degree of disease, if you will, isn't necessarily reflected by the level of interferon signature. And the most extreme examples, as I've shown already, are these patients who, well, actually, no, it's quite interesting. Actually, in the COPA patients, it is true, in fact, that the patients who are the mutation carriers who are clinically asymptomatic essentially don't show a signature. So actually there, the signature does mimic or does follow with the clinical phenotype. Where what I didn't really show was patients with, I glossed over, I went through a slide that I didn't talk about, but perhaps I should have done, which is persons with mutations in MDA5 in particular are very interesting, because there, with mutations in MDA5, there's about a 13% non-penetrance rate. And those patients who are clinically non-penetrant, completely asymptomatic into their 50s and 60s and 70s, they still demonstrate, I think someone might need to mute, they still show a very significant interferon signature. So there it's true. It doesn't match with the interferon, it presents with the difficulty of who would respond. Well, I think you treat whoever's got, you know, bad disease. But what the other thing we've learned is, I mean, and this actually could take me a few minutes to talk about, so I probably won't, but we have found that the interferon signature at the doses of JAK inhibition that we have used, the interferon signature is not a very helpful dynamic marker. So we've never really been able to suppress it fully. Although, I mean, if I then look at our experience with dermatomyositis, what I would say there is when you make a patient with dermatomyositis better, interferon signaling is better. So I think we need to do more work. I think that, you know, it's partially true, it's partially not true. I don't think that JAK1 inhibitors are the answer to all our dreams or all our, you know, all our wishes. Yeah.
So how much time do you have for questions? Can you answer a few more?
Yeah, I can. Yeah, a little bit more. Yeah.
Okay, sir. So the next question is from Dr. Amit Rawat. So you have asked, you have mentioned DNA repair defects such as ATM artemesis as a cause of type 1 interferonopathies. Is the CNS damage in AT partly mediated by elevated interferons? Also, any update on the use of reverse transcriptase inhibitors in type 1 interferonopathies?
Yeah, okay, so I think this is a very interesting question. So I didn't put it up, but what I would say to you in very general terms is I think that if you look at that catalogue of diseases that we're classifying as type 1 interferonopathies, I think some of them are more interferon dependent than others. And I would say to you, I think currently that AGS is a sort of kind of pure interferonopathy, whereas I think mutations in Artemis and ATM, you know, they're impure. And I suppose one simple explanation, you know, you could say, well, the interferon's nothing to do with anything, you know, and if I say to you that 13% of people, of mutation carriers, 13% of persons that we've identified carrying a mutation in MDA5 or FEH1 demonstrate a signature but are clinically asymptomatic, it would be not unreasonable for you to say, well, Yanick, it's all a load of rubbish. You know, the interferon has nothing to do with anything. You're telling me there are people who are, you know, completely clinically asymptomatic with lots of interferon. Well, there you go. But what I would say about the Artemis and ATM is that it also brings up another point. These proteins that are mutated, some of them have, well, they all probably have more than one job. But I would say that ATM and Artemis, for example, they have their major function is in DNA repair. And the kind of the interferon stuff is a kind of adjunct, it's an offshoot, if you will. Whereas I think in TREX1, say, its day job is to sort out, make sure you don't misrepresent self as non-self. So I think that's sort of, and as, we've never tested, I think it's a great sadness. I'd be very interested to test the cerebrospinal fluid and the blood of patients with cocaine syndrome. So they have white matter disease, they have calcification, it's a DNA damage, DNA repair disorder. Do they have interferon signaling? Is their brain phenotype due to too much interferon? I don't know the answer to that, but I'd put a small, a pound on that, but I'd bet something on that. Yeah.
Everyone is not unmuted. Dr. Nihas?
Yes, sir. Yes, yes ma'am. Yes, ma'am. So we'll go to the next question. So next question is by Dr. Rajesh from Calicut. He's telling, we had a child with AGS with IF1H1 mutation who presented with warm and antibody autoimmune hemolytic anemia, who also had a stroke during the recovery phase. So how commonly is autoimmune hemolytic anemias in your cohort with other AGS related mutations?
Yeah. So I can't give you a precise figure, but I would say to you that we've seen it not infrequently. So we see a lot of it in SPENCT, SPENCT is very rare actually, but a lot of the patients with SPENCT had autoimmune hemolytic anemia. And we've seen it sometimes in MDA5 mutations. And what we've found is that in a very small number we've treated, it's responded well to the JAK inhibition. I'm interested in the fact that the child had a stroke during the recovery process. That's interesting. But yeah, I think it's worth, that's an example, I suppose, of what I'm suggesting, where you get this kind of spillover into. But one thing I just mentioned here is that if you play a word association game with a lot of physicians, if you say interferon, to a lot of physicians and say, what's your word association? They'll say lupus. But actually, although we do see lupus in some of these monogenic disorders, it's the exception and not the rule. Except with SPENCT, where really it's very common. So anyway, yeah, that's going off piece a little bit. Thank you.
Okay, sir. Next question is there any screening test prior to genetic testing, like DADA2 levels in DADA2? How practical is looking at interferon signaling as a screen? Do all symptomatic patients have high inflammatory markers? Also, should all cases of familial lupus be checked for interferonopathies?
Yeah. So is there a screening test prior to genetic testing like DADA2? Yes and no. I mean, I would say in some respect, yes, the interferon signature, I think is a great test, but no, because it's not specific. The DADA2 test for ADA2 is a very specific test. So that's great. We don't have that. We don't have an enzyme. We don't have that. So okay, that's the way it rolls. How practical is looking at interferon signaling? Well, it's very practical. I mean, we have literally done thousands of these. We published a paper in Journal of Clinical Immunology in 2016 where we said, I think at that time we'd done 2,000 of them, and we published results on almost 1,000 of them. It's very practical. It's not inexpensive. I mean, it's practical because we use a Paxgene tube, and the Paxgene tube is great because it travels at room temperature. So that means you don't have to prepare serum. You don't have to have a fresh sample. It can travel at room temperature, and it lasts at least for 72 hours. And then you put it in the freezer. So it's very practical, but it's not. It takes some work, and it's not. It costs about £80 a time, or it costs us about £80 a time. So you know, it's not perfect in that respect, but it's very practical. We do it all the time. Should all cases of familial lupus be checked for interferonopathies? Well, I don't know. I mean, I suspect that if you've got familial lupus, they're going to have a raised level of interferon. So I don't know if that's going to help you, except that what I would say to you more generally is I think that the ACR criteria for lupus are terrible. I mean, they're so imprecise, which is why I think people have a lot of problems with the diagnosis of lupus. And I don't know really why people don't do interferon. Well, I do know why, but people should, in my opinion, and they will at some point, I believe, do interferon signaling as part of the diagnostic criteria for lupus. And then more generally, you know, if you've got familial lupus, then that's unusual, especially if it's early onset. And we and others are looking for Mendelian causes of that, and I encourage you to do that. Yeah.
Okay, sir. The next question is from Dr. Santhya. So the question is there any reason why interferonopathies do not have predominant myositis as compared to the phenotype seen when antibodies against viral sensors are present, as in immune myositis, where interferon is an important part of pathogenesis? Okay, so that's a nice question. Well, it's interesting, and I think it's touching on something that I didn't talk about. But so if I think I'm going to read between the lines. So when I went to Paris in 2014, the STING papers were published by Raffaella and a colleague in Imagine, Frederica Loca. And I also began knocking around with pediatric rheumatologists. It's the first time I'd ever done that, really, because I've been mainly involved with neurologists. And, you know, I got interested in dermatomyositis and connective tissue disease and the overlap between SLE and DM. And, you know, it all got a bit confusing in my head. And then I realized there was this very, you know, I think it's quite impressive the way people can classify dermatomyositis on the basis of the antibodies. And of course, there is this antibody positive, MDA5 antibody positive subtype of dermatomyositis. And they're very interesting because they don't always have any muscle involvement, but they can have lung involvement. So the lung involvement, STING, COPA, I just thought to myself, oh, this is all going to be due to STING mutations or COPA mutations. So we did a bit of sequencing in dermatomyositis, and we didn't find anything. But you know, it is fascinating. How come these antibodies against MDA5? So that subgroup of dermatomyositis as the subgroup has the most type 1 interferon signaling. It's really, really, really strong signal. Why don't patients with AGS get muscle disease? Well, they don't get dermatomyositis, it's true. Why don't patients with AGS get lung disease? They don't really. So how come COPA gets lung disease and STING gets lung disease and AGS doesn't get lung disease? How come STING gets skin disease but COPA doesn't get STING disease? If it's all about interferon, Professor Crow, how come they all don't show the same thing? Your theory is rubbish. So, you know, again, it could be a rubbish theory. I'd also say that, you know, as I mentioned earlier on, some genes have a day job and then they have another job. And you know, some genes are expressed in some tissues and not in other tissues. Some genes might be redundant in some tissues and not in other tissues because of expression of another gene that does the same job in that tissue. So I think these are all fascinating questions. I don't think they blow a hole necessarily in the hypothesis, but you know, I come back to the statement. This is an hypothesis, and we have to prove it. Okay, thank you, sir. So next question is by Dr. Sunita. She's asking, do SLE patients with predominant neurological manifestations have something like to do with more interferon signature than those without? Sorry, say that again, please. Yeah, sure, sir. Do SLE patients with predominant neurological manifestations have something like to do with more interferon signature than those without? Yeah, so that's a good question. It's one of the questions we're trying to look at the moment. So we are interested in patients with SLE who have neurological involvement. So, you know,
somewhat vague term, neuropsychiatric lupus, exploring with a close colleague who's still affiliated to the lab, did a PhD in a lab called Isabel Melki, where we are looking at interferon signaling in blood and in cerebrospinal fluid. And our data suggests that there is increased levels of interferon alpha protein in the cerebrospinal fluid of those individuals. So I'm not surprised. And in fact, if you look at the old literature, even in adult SLE, there's quite a high percentage, or there was when people were doing CT scans. Problem with MRIs is you can miss a lot of calcium. And you can have a lot of calcium in your brain without having any obvious neurological features, at least at first. But if you look in the old literature, there was quite a high percentage of, several percent of patients with lupus have been described to have intracranial calcification of the basal ganglia. And I've mentioned already that I think that's a telltale sign in some cases of too much interferon.
Thank you, sir. So we have a couple of more questions. Can I go forward, sir?
Yeah.
Sure. Okay, sir. So next question is from Dr. Amrita Agarwal. How many gene ISG is sufficient to give a good read out of an IFN signature?
Yeah, so it's a good question, and I think there isn't a right or a wrong answer. I mean, you could do one, but I think that would be dangerous and a bit silly because some of them, I just don't think it's enough. And there's one gene in particular, IFI27, which can be very high, sometimes even in controls. It's a remarkably labile gene. We were doing 6. We now do 24. You could do an RNA-seq experiment every time. Of course you could, but that would be expensive. MedImmune, or as a kind of companion diagnostic for anifrolumab, at one point at least, they were describing a kind of companion diagnostic test with 3 ISGs. I mean, personally, I think the NanoString platform that we now use has 24 ISGs, and I think that's plenty. But we did several thousand of these using 6. It's really a question of cost and time, but I think you need to do more than, I would say 6 is a good number. Less than that, maybe you could get away with 4. The important thing partly is also about, as I mentioned, serial testing. That's important. Once if you think you've got the clinical phenotype, okay, but where you don't know what's going on, you need to do it several times to make sure it's not false positive. Yeah.
Thank you, sir, for that nice question and answer session we went through. So that is from the question and answer session. Thank you, sir, for that nice session and nice talk, which you enlightened us on the interferonopathies. And I hand over the mic to Dr. Geeta, madam.
Yeah, thanks, Nihas, for doing the question and answer session. We have Dr. Kishore Warrior from the UK, our old student who's now a leading pediatric rheumatologist over there. Dr. Kishore, a few words from you. Dr. Kishore, I think, can you unmute yourself, Dr. Kishore?
Hi, Prof. Thanks ever so much for another fantastic talk. It was a pleasure to be part of this. And I think it was important that we did this because it's a relatively new concept for many of my colleagues back home in India. And I'm sure they would have appreciated and they would think about it when they come across patients with these clinical features, which is the whole idea of actually introducing this topic among the general pediatric fraternity in India. And thank you very much for doing that.
My pleasure. Thank you for the invite, and I'm very happy to answer questions by email. I mean, I always try to respond to emails. So yeah, good, fantastic. Thank you all.
We have a few words from Dr. Vinod Skaria, who is a computational biologist and molecular geneticist at CSIR IGID Delhi, and who collaborates in a great way, a fantastic collaborator in our primary immune deficiency project. Dr. Vinod?
Thank you, Professor Crow, for the fantastic talk. It's indeed a pleasure to learn more about the work that you do, apart from the publications, of course, many that you have published on these diseases. Thank you very much.
My pleasure. Thank you for giving up your Friday evening.
Dr. Vinod is the scientist who's done work with the zebrafish models, and they use that in their lab as one of the model organisms. So I thought you would like to speak to you. So it's been really a fantastic eye-opener, this talk. And actually, we would like the pediatric audience to know more about these rare disorders, which may not be as rare as we thought they were. Like, for example, we thought hyper IgD syndrome was only seen in the Mediterranean, and it would not be present in this country, but we are having to change our opinion rapidly. So it's really nice, and I'm sure a lot of young pediatricians would be inspired by the great cutting edge research you're doing right now, and would look for these diseases. And it's really gratifying that you not only find these diseases, elucidate the underlying pathogenic mechanisms, but also find treatments so that the quality of life for these children and their families improves. That's really fantastic. And it's really nice that you spend so much time answering all questions. I'm sure you have a busy schedule, and I do apologize for the little technical snags we had. Some people getting unmuted on and off. I'm very sorry for that. I'd like to thank all the delegates who have wholeheartedly participated in this session and asked lots of interesting questions and joined in the deliberations. I'd like to thank Dr. Kishore for all his help in arranging this session. And Dr. Ajit, would you want to say something, Dr. Ajit?
No, actually, it was an eye-opener, Dr. Yanick Crow, and really interesting aspect of the research. I hope that such type of research also gets being done. It should be done in our country. Like, I think we can collaborate and in areas where we can, and this is a platform for that too, and for collaboration and
Sure.
in research.
Yeah, no, I think that's
The
right.
talk
And,
is really fascinating. Yeah, it's really
thank you.
nice.
So I think, I mean, I just mentioned, I think that Aicardi-Goudji syndrome is much more common than people realize. I mean, all these things are rare, but as a rare disease, it's really one of the most common diseases. You know, it's an important disease to know about. And then anyway, yeah, if I can help in any way, let me know. Fantastic.
Thank you. Thank you very much. Bye.
Good.
Thank you so
now.
much. Yeah,
Take care.
thanks for this scintillating talk. Shall we close then?
Yeah.
Thank you so much from all of us.
Okay, ma'am. Thank you.
Good night. Thanks,
Bye-bye.
Dr. Nihas, for being a
Thank
wonderful host. Thanks.
Safe travels. Bye-bye.
Thank you, sir. Thank you, sir, for being.